recorded. If you require any further assistance, please press *0. I would now like to hand the conference over to your speaker today, Mr. Michael Schomer. Please go ahead, sir.
Thank you, operator, and thank you for joining us for the COVID-19 media call for December 1st. We'll start today's call with comments from Health Commissioner Jan Malcolm and MDH Infectious Disease Director Chris Earsman. After that, we'll open it up for questions from reporters on the line. With that, we'll now turn it over to Commissioner Malcolm.
Thank you, Mike, and good afternoon, everyone. Well, around the world, we continue to add over 500,000 new cases every day, and unfortunately, just under 10,000 new deaths a day. So all around the world, we're now at a total of 63.3 million people having been infected with COVID-19, and sadly, over 1.47 million deaths. In the United States, we're adding in recent days over 150,000 new cases a day. Yesterday's total was 161,000, and death numbers are rising at the rate of between 1,000 and 2,000 a day. Yesterday's increase was 1,216. So we now have 13.5 million Americans having been infected with COVID-19 and just over 268,000 deaths across the country. Here in Minnesota, we reported another 3,570 cases this morning on a volume of 22,757 tests processed yesterday. That brings us to a new total of 322,312 confirmed or probable cases in Minnesota through laboratory testing. Yesterday, we had reports of another 22 people having lost their lives to COVID, for a new total of 3,543 deaths among Minnesotans since the start of the pandemic. Of the deaths reported yesterday, 10 of them were from the metropolitan area, 12 in greater Minnesota, ages ranging from 50s to over 100 years old. And 5 of these deaths were among residents of long-term care facilities. In terms of hospitalization, since the start of the pandemic in Minnesota, there have been a total of 17,111 people hospitalized in Minnesota for COVID, and 3,826 of them have required intensive care. Currently, there are 1,840 people in Minnesota hospitals with COVID-19. 394 of them are in intensive care. The 7-day average testing positivity rate has continued to improve a bit. It is now at 11.2%, which is down from 14.4% the week prior and 15.4% almost 2 weeks ago. Though that is certainly an encouraging sign, but as we have said a few times now, it's too early to consider this a permanent trend. And again, remember that the positivity rate is as of a week ago, given the lag factor. So that is data as of November 22nd. As we shared in our briefing yesterday with Governor Walz, these daily numbers can and do fluctuate. But the overall message from the data and from the longer term trends is that we do remain in a very critical stage of the pandemic. We know, based on the rapid case growth of last week and the week before, that we are still in for some very challenging weeks ahead in terms of tight hospital capacity, and of course we await to see the effects of the holiday gatherings and travel. While we thank Minnesotans for the adjustments that so many made in their plans, and that was difficult to do. We do know that there are challenging weeks still ahead, but we also know that those challenges really are temporary. And if we all work together and can keep on taking these very basic but very effective measures of masking, social distancing, and staying at home, and testing as appropriate, we can get through faster and with more of us getting through in a healthy state into those better days that we know are ahead of us in 2021. As we've said many times, we are concerned about the current situation, but very optimistic that as the Assistant Secretary for Health of the United States, Admiral and physician Brett Giroir said over the weekend on some of the national news shows. We are not passive bystanders here. We have it very much within our control through the decisions that we are making individually and collectively to influence the course of these next weeks. And again, I think more and more we're hearing signs of encouragement and optimism from our federal and state leaders about that future coming closer, thanks to the ongoing progress with vaccines. And to that end, I've asked Chris Erzman to join us today to share some general news on that front. And we'll just mention that we are planning a more in-depth briefing for the media with Governor Walz, a briefing for the media and the public with Governor Walz probably sometime next week. And with that, I will turn it over to Chris.
Thank you, Commissioner. I know that the past 9 months have not been easy, and certainly not having Thanksgiving with my family was not fun for me. We want this to be over. We all want COVID to be over. And people have been asking, what is the end game for COVID-19? And it is vaccine. And so I'd like to talk today about that end game. We are looking at some very promising news related to safe and effective vaccines, and we're seeing them coming much sooner than many had thought possible. There's been good news on that front, and I'm sure many of you have heard that. And so I'd like to tell you what we know about COVID-19 vaccines for Minnesota. First of all, the fact that we're talking about a vaccine less than a year from when the virus was identified is truly amazing. And so some of you may wonder, well, did anyone cut corners with safety to accomplish that? And the answer is no. COVID-19 vaccine development was accelerated, but it was accelerated in ways that did not impact the important safety steps that we expect to happen for all vaccines. And I'll just mention a few ways of how things were made more efficient. First of all, manufacturers were able to get a jump start in developing a COVID-19 vaccine because they were able to use other research and vaccine technology developed over the past decades. So that helped them move ahead. Then parts of clinical trials were done at the same time instead of one after the other. For example, people were being recruited for the phase 3 trials, even as the phase 1 trials were still going on. Now, this didn't shorten or weaken the earlier trial phases, but doing the recruitment work ahead of time instead of in sequence helped to save time in the process. Another thing that's happened with the COVID-19 vaccine is that usually manufacturers wait to make the vaccine until they know it is approved for use by the FDA. But in this case, the federal government stepped in and is covering the cost of creating vaccines while they are still being evaluated, so that a supply of vaccine is ready as soon as it's approved. It's important to emphasize that only the vaccines that are shown to be safe and effective will be used. If a vaccine fails to meet these stringent requirements, it gets tossed out. And that's where the federal government is covering that financial cost for the pharmaceutical companies. And that's why they're able to go ahead with manufacturing in advance. The same safety expectations that we have for all vaccines apply to the COVID-19 vaccines. They have to be safe, pure, and effective. And the clinical trials that are currently underway are the same size as for other vaccines over the last years, and they include people from many diverse backgrounds. So when we look at the process for vaccination, we're delighted at how quickly we've been able to move forward. And I can say with confidence that the ways that we've been efficient have not impacted vaccine safety. Right now, there are multiple vaccines in various stages of clinical trials, and 2 pharmaceutical companies, Pfizer and Moderna, have reached the point that they have submitted data to the Food and Drug Administration for review and approval. And the good news is that the initial data they shared publicly suggests a high level of efficacy or effectiveness of the vaccine at 95%. So what happens now? CDC's advisory group, the Advisory Committee on Immunization Practices, or ACIP, is meeting this afternoon to review data and make recommendations for who should receive the initial doses of vaccine. These are called priority groups. And as exciting as all this is, it's important to keep in mind that there will not be enough vaccine initially for all the people who want to receive it. For this reason, we're planning for vaccination in phases, with different groups and populations gaining access to the vaccine at different times. The ACIP and the Minnesota Vaccine Allocation Advisory Group will provide guidance about what those phases will look like in the coming days and weeks. The Minnesota Advisory Group is made up of public health, medical, and community partners to help advise the state on equitable and effective allocation of the COVID-19 vaccines in Minnesota. And they will be making their recommendations based on what comes from the federal ACIP. In the first phase of vaccine availability, or phase 1, vaccination activities will be targeted through local and regional public health plans to specific settings that is not open to the public, but settings that serve certain populations, like healthcare workers. In phase 2, vaccine supply will increase enough to start to meet demand, and vaccine will be broadly administered through a network, including clinics, pharmacies, and public health sites. Phase 2 represents a time when certain groups will continue to be served by this expanded network. And those groups would be individuals who are most vulnerable and have the most severe impact from COVID disease. And during phase 2, at the end, we will start to be able to expand to open up for general vaccination of the public. And then in phase 3, vaccine will be available in plentiful supply. And so we will look at how we will routinely distribute COVID-19 vaccine. And that will be a wonderful time. We will be looking to the recommendations from ACIP and the Minnesota Vaccine Allocation Advisory Group to help us apply the guidance to Minnesota in a fair way that keeps health equity top of mind. More information will be coming on these recommendations in the next days and weeks. Now that conversation was really about priority groups for vaccination, but before we can get to priority groups, we need to know that the Food and Drug Administration has determined that a vaccine is safe. And so the FDA has an advisory group. We call it VRBPAC, but its real name is Vaccines and Related Biologics Advisory Committee. So VRBPAC is scheduled to meet on December 10th to review the Pfizer vaccine data, and on December 17th to review the data from the Moderna vaccine. They will be looking at the data from clinical trials and will make a recommendation on whether to license or authorize these vaccines. Safety is our top priority in Minnesota, and we will not distribute a vaccine that does not meet the necessary standards. Once the FDA makes a decision, then the ACIP will meet again to make additional recommendations for vaccination. So we have all those steps to take place, and once those last federal recommendations happen, we'll still need about a week in Minnesota to make sure all of our guidance, education, and training has taken place before we start giving vaccines. An important part of vaccine safety and effectiveness is that it's given and stored appropriately. So we want to make sure that not only is the vaccine itself pure and safe, but that the way we store and administer that vaccine is also safe and appropriate. So we want to make sure that our healthcare providers and partners have all the information to be able to do that. We'll be hearing about this process and more details about the phases, recommendations, and availability in the coming weeks. We know there's a lot of excitement and people will have more questions. We encourage people to find the latest information on COVID vaccines on our website as well as CDC's website. So just remember that it will take some time for vaccine to be rolled out to everyone who wants it. So we will still have to stay vigilant with our practices of social distancing, masking, and hand washing for a while longer. And I will say that you should be washing your hands long beyond when vaccine is available. But for sure, social distancing and masking while we're waiting for the vaccine to be widely available. We've been talking about the light at the end of the tunnel. It's there and it's getting closer all the time, but we do have to stay the course a bit longer before we reach it. Vaccines are the exit strategy from the pandemic. And for now, as we prepare for that exit, we need to focus on making sure as few Minnesotans as possible get COVID in the coming weeks. We want everyone to be there in full health to celebrate with us. Thank you. And with that, I'll turn it back to Mike Schomer.
Thanks, Chris. Operator, we're ready to take questions.
Thank you. At this time, as a reminder, to ask a question, you will need to press *1 on your telephone. Again, that would be star, then the number 1 on your telephone. You have your first question from the line of Jeremy Olsen from the Star Tribune. Your line is open.
Yeah, hi. I just wanted to ask about that light at the end of the tunnel. One, I mean, that's a pretty precipitous drop in the positivity rate, and that's been held out as a key indicator of pandemic severity all along. But two, you look at the rates in our neighboring states, and we almost have the same rate as North Dakota right now. So, I mean, is it wrong to interpret this to say that we're kind of just the last car on the roller coaster and we're just getting pulled over the hill right now? It seems like the light's there.
Yeah, hi, this is Jan. That's an interesting analogy, Jeremy. We'll have to think more about that one being the last car on the roller coaster. I would ask Chris to comment on, any relationships you'd like to call out between the levels of case growth, which do continue to be extremely high, and falling test positivity, which, as we've noted, is certainly a helpful sign. But we talk a lot, and we talked some yesterday about the importance of the lag period. The week or so after, while data is still coming in, before we start to include those data in our calculations. And we do know that in the current lag period, the test positivity rate is inching up a bit again. So what we don't know is how long these trends will persist, how high they may go or how low they may go. And as I also mentioned yesterday, we've sort of seen this wave-like pattern before in the pandemic, and we may expect to see that again with some times of improvement followed by some times of increases again. But Chris, anything you'd like to add?
Yeah, I think what I'd say is that the encouragement that we see in these short-term kind of daily bursts is certainly, always good. I always say I celebrate every day where case numbers are lower than the day before. It's just that we're in a bit of a tenuous time. We've just come off of a lot of testing prior to the holiday, people who were hoping to get tested and use that as a justification to go forward with plans. We know that testing volume decreased the week of the holiday, and so there's just been a lot of variability. And so I'm really reluctant to draw too many conclusions at this point because it really has been a very unusual week. We went from, having a 2-day range of 9,000 cases, which, roughly, if you averaged it, would be 4,500 a day, to the next day having almost 9,000 cases in a single day, and then dropping down to 6,000 cases. So we've seen, as the commissioner said, a lot of variability. And so I think it's important that we, are cautious in how we're looking at this particular week, because it not only do we see normal, fluctuations in our case numbers, but we're seeing really big ones, and this is a really unique week. So I think that's how I would be cautious in interpreting it. And while it's great to see numbers, drop or positivity drop, all of those things, that won't truly be the light at the end of the tunnel, because we want to make sure that we've got the whole population protected, and that's going to take vaccine.
My follow-up question is on a number that hasn't been as discussed as much lately for a lot of reasons, but the unknown community transmission rate, it's jumped. It kind of floated around at low 30s, but now it went from 32 to 37%. And I wonder if you have any interpretation on that. Is that, I mean, you've talked about whether you need to redo contact tracing efforts because of the overwhelming number of cases. Is the rising unknown transmission rate reflective of that difficulty to keep up, or is there something else going on there with that rising number?
Yeah, I think I'm going to ask Chris to take that one, Jeremy. I think the short answer is yeah, we think there's a relationship, but I'll let Chris go deeper.
Yep. I think that, part of the challenge is that, yes, we're getting, 9,000 cases in a day, and it's challenging to be able to keep up with all those cases. But I do think that, as we see more and more spread within the community, there are just more and more opportunities for people to be exposed. And so it's going to be less likely that people can identify exactly, where they may have come in contact with someone. Early in the pandemic, there were so few cases that, man, if someone was a case, it was so much easier to draw that circle around them and identify potential contacts. Now there are so many cases that it's becoming more difficult, and so the likelihood of having more unidentified community spread is much greater. Did that answer your question? Okay.
Yeah, it did.
Thank you. Your next question comes from the line of Chris Maggin from Pioneer Press. Please go ahead.
Hi, thanks. I wanted to ask about a detail on the updated hospital capacity webpage that you've been updating throughout the last few months. It shows a surge capacity for hospital beds and kind of breaks down, I think for the first time, how many of those are available and how many of those are in use. And it looks like central Minnesota is the region that's tapping into those already. And I was just going to ask you to sort of kind of reiterate what exactly surge capacity means. And I mean, is that the opening of a new facility in order to handle overflow patients, or just adding beds and staffing to existing hospitals, or what does that mean, and what should we be watching for as we kind of keep an eye on hospitalization rates?
Well, thanks, Chris. This is Commissioner Malcolm. I think what I would add, and you're right about the increased level of detail on the webpage. We're happy to be able to show more of a regional breakdown and a little more clarity about not only the beds available, but the staffed beds. As we've talked about a lot in recent days, the concern has shifted from physical capacity in terms of number of beds and equipment like ventilators to the ability of the health systems and the hospitals to staff the beds, whether those are beds that are regularly in use or surge capacity beds. So that staffed beds piece is really the critical thing to watch. Yes, it's the case that some regions and some individual facilities are tapping into their surge beds. What that really means is that these are beds that can be added for either medical, surgical, or more often ICU repurposing spaces that don't typically have ICU capability into ICU, or adding more beds into the hospital where they hadn't been. But the first in the priority will be to increase capacity within the hospital setting rather than opening up entirely new facilities. So the surge beds that are reflected there on the webpage reflect the capacity that has been identified and planned for by the health systems that could be added to the existing capacity. But again, the really critical variable becomes the availability of staffing to staff really any level of those beds.
Okay, thank you. And just to follow up on that, when it comes to capacity in general, there's been some discussion about the building that the state purchased earlier this year to serve as an overflow mortuary, and I'm just wondering if that if you see that being needed in the near term or at all.
Well, we certainly hope not. But I think that was just that was a matter of trying to think ahead and plan for something you hope to never have to use. But the short answer is we will be prepared to open that facility if it's needed. But what we're doing right now is much the same as what's happening with the health systems, trying to just maximize the use of all the capacity that exists among funeral homes, mortuaries, and before we would open that facility, we would want to make sure that we were fully utilizing the capacity that exists, and that's where we are right now. We're trying to get a better handle on capacity in the system and where we are in relationship to that capacity, much like we are doing with hospital beds.
Thank you.
Thank you. Your next question comes from the line of Megan Ryan from Minneapolis Star Tribune. Your line's open.
Hi, thanks for doing this, both of you. My question is actually in reference to the University of Minnesota and the current outbreak that's on their football team. I know that they've been working, with MDH closely as they've said throughout this process, but I'm kind of wondering from your perspective, how have you guys been helping them navigate through that? And maybe specifically, have you guys been helping them contact trace? I know you just said it gets hard when there's, so many cases and it's hard to determine where it's come from, but I guess I'm curious with the football team, if you've done any, look into what's been going on there and how that has grown to 47 cases and, who maybe brought it in or how it was brought in and then how it spread so quickly, even though they've got daily testing with that.
Jen, could you take that one? Yeah.
Okay. Yeah.
Thanks. Yeah. So Megan, we have teams that in addition to the case investigation and contact tracing group, we have teams that focus on different sectors. So sports, schools, long-term care, all of those things. And so yes, the team that we have that deals with sports type exposures and outbreaks has been working with the university on this. And so, they have assisted them in providing guidance. The university and the football team staff obviously know more about the interactions between their coaches and players, but our team provides them with information about, what they should be looking at, what they should be looking for in terms of, best practices or what kinds of exposures are of concern. I think the challenge is that any time that you have a group that's so closely integrated and working together so much, that poses challenges for transmission, regardless of whether or not you have frequent testing. So I think that's part of the challenge. And I would let the university speak to, what they think in terms of, how it was introduced and things like that. I know that they have been very involved with our team and we have been working with them, but I think they should probably be the ones to speak to how things, transmission within their team.
Mm-hmm. Yeah, no, that's fair. I've kind of asked that question to them. They've professed to not be sure. So I didn't know if, they were working with you and you guys had having a conversation with them about that. But I guess as a follow-up, you kind of mentioned that, when you have a group of people together, regardless if they test every day, things can happen. I was wondering if you could kind of expand on that, because I know when the Big Ten decided to come back and play football, them having their daily testing, that was at the time the most stringent protocol of any of the football conferences, for college at least. And they were saying, when you test every day, it eliminates the need for contact tracing because you take people out of the equation as soon as they're positive and all that. But obviously, you're seeing that there's been, not just on University of Minnesota, but other teams too, there, even with daily testing, these things still happen. So I guess if you could kind of maybe speak to that or why maybe daily testing is not the kind of foolproof solution that maybe people thought it was just on the surface.
Certainly. Well, a couple of things. One is just keep in mind that daily testing was happening, not only in sports, but it was happening with the White House and happening lots of places where we have, seen transmission happen. And so the good thing about testing, and the reason that we encourage people to get tested if you've been exposed or that type of thing, is your goal is to identify a case as early as possible. So you want to make sure that if someone tests positive for COVID, you know about it right away, so you can get that person isolated and take, really quick action to mitigate additional spread. But the challenge is that, you can have a situation where someone can come in who's infectious and could have the potential to expose people even before they get tested or get their test results back. And once that's happened, those people have been exposed. Once it gets introduced, all the testing will do is help you identify that you've got cases and get them isolated quickly. So the good news is, for instance, it's not good if you're a football fan, but the good news is for the Gophers that they identified cases and use that to make decisions about their future competitions. And so that in and of itself helps to keep the spread from moving between teams. But it is challenging within a particular team because it's possible for transmission to have occurred even as a person's coming in to get tested. So it's not foolproof. It certainly helps a lot, but it's not foolproof. And again, that's why I'll go back to the vaccines as the light at the end of the tunnel.
Awesome. Thank you.
Thank you. Your next question comes from the line of Peter Cox from Minnesota Public Radio. Please go ahead.
Yes, hello. I'm wondering what state officials think is behind the rising cases, positive cases in the Hispanic community, and if MDH is doing anything in response to that.
Chris, could you take that one too?
Sure. We're continuing to look at our data by race and ethnicity, and we have teams that are doing outreach in communities. So in other words, we have community leads who are working with various communities across the state, including our Hispanic community, to make sure that they have information and access to testing. And so we're continuing with that as a support, but I can't say that there was any particular event that we're aware of. So a particular social gathering, a particular workplace that would account for any increased transmission in that community.
Thank you. One other thing I'm wondering about is if you have any update on the long-term care staffing issues that we were seeing a week and a half ago.
Yeah, I can. This is Jan. I'll speak briefly to that, and then Chris, you can certainly add. We do continue to see increasing numbers of both staff and resident cases in these facilities. We are working at the state level. We're working with 56 facilities currently that have staffing support needs. We've talked about the fact that we've set up a system, really a several-pronged system to be able to support facilities. They can let us know when they have current or projected challenges. We have crisis staffing managers that work with them. We have a volunteer registration system that helps to connect willing volunteers, health professionals and others with the facilities. We've utilized National Guard teams. We've had the benefit of some federal public health nurse resources who have been on site in some of the facilities. So we've deployed a lot of different strategies, but it is very definitely an ongoing challenge. And again, we just keep reinforcing another of the reasons that we really need to manage the community spread in order to protect this workforce.
Did many state employees respond to the request for help there?
Yeah, we did field a survey that I think folks are generally aware of, just inquiring, for asking really for people to just register their interest. We would have a lot of work to do to actually set up the system, but we were gratified that a significant number of state employees did say that they would be interested and willing to be part of that volunteer force if needed. Some of the folks who volunteered, are working in high priority jobs that wouldn't be able to be reallocated. So I can't give you a precise number right now, just because we haven't, kind of gone through who among the group that volunteered would actually be eligible for redeployment. But we appreciated that people took the time to respond and did. And there was not in the thousands, more in the hundreds, but that people did step forward to express a willingness.
Thank you.
Operator, we have time for one more question.
Thank you. Your last question comes from the line of Susan Elizabeth Littlefield from WCCO-TV. Please go ahead.
Hi there. I was interviewing earlier today a woman, and her 6-year-old had COVID, thankfully recovered and everything. But when I asked her about the vaccine, she said, I'm really worried about giving a vaccine to my kids and what the long-term effects could be. How do you address that?
Well, a couple things right off the bat. First of all, the vaccine will initially not be available for children. They are just starting to include children in some of the clinical trials. So it won't be something that's an option for kids right away. The goal is to have, because kids are a special group, and so the goal is to have even more data about use in adults before it's made available to children. So I think that by the time that this mom has to make a decision about vaccinating her 6-year-old, I think that she will be able to feel much more confident, both with the data that comes from the clinical trials as well as the experience that we've had in vaccinating the population before we do children.
Any idea on a loose timeline then for kids? Like, would that be an extra year down the road? What's your feel?
I don't know that it would be an extra year, because certainly there are aspects of the approval process that you can skip. So in other words, proof of concept and some of those things, it really is more the phase 3 clinical trials. And so they're looking at how best to accomplish that in a manner that provides them with the information that they need about children, but does it in the way that is the safest for those kids. And so I think it's fair to say that we'll see vaccines for adults now coming in the next weeks and months, and then it will be, later that we are able to vaccinate kids. So not years, just to be clear, we're not talking about years from now, but we're talking about the fact that that's not a concern that mom will have to have in the next month or two. Thank you.
That's all the time we have for this afternoon. If you do have any additional questions, please feel free to reach out to our communications office this afternoon.
That was today's COVID-19 briefing by State